Hi guys, welcome to another week of virtual learning. Yay! Or maybe not so yay, but we can do it. Only a few more weeks, guys. Only a few more weeks. Hang in there. Let's see. So today is going to be catch-up day. We've got lots to cover. We're going to go over ED first, and then we're going to follow it up with SLD. Just some things to keep in mind. I'm going to have things posted on Blackboard for y'all to access. One thing that you want to make sure you have pulled up is the form that says Sam and Barry observation form, something along those lines, but look for Sam and Barry. Alrighties, because there's going to be a video I'm going to ask you to watch. You're going to complete that Sam and Barry form. And then you're going to upload that onto your Blackboard discussion post, which I will create for you, develop for you. So that's for the ED lesson. And then for the SLD lesson, it's going to be a different discussion board. Alrighties? Just for the SLD presentation, just jot down some takeaways, some thoughts, things that's really stood out to you or you found interesting. So take notes for the second half, alrighties? That will be our SLD lesson. Okay, let's dive right on in. Here we go. ED. Okay. Alrighties. Okay, first off, let's start with defining EBD. Guys, EBD is just a umbrella catch-all term for students who are struggling with emotional behavioral issues, alrighties? EBD is just an umbrella catch-all term. So if you've got a kiddo struggling with anxiety, that would be under EBD, an emotional behavioral disorder, or depression. It would also be under EBD. EBD is a catch-all, alrighties, and then you've got your specific difficulties such as, say, anxiety and depression. So when we define what EBD is, we have to start first by it's this inability to learn that can't really be explained by, say, sensory or health factors or intellectual factors. You're going to see these are kiddos who have a really hard time developing and maintaining relationships with others. They're going to have really inappropriate behaviors or feelings under very normal circumstances. And we're going to go over these different subsects in just a wee bit. They're also going to demonstrate what's called pervasive mood of unhappiness or depression. There's also going to be these physical symptoms or fears associated with either personal or school problems. Other considerations to keep in mind. Characteristics of ED exist to a marked degree, alrighties, and this is coming straight out of our Ed Code and or our IDEIA federal regulations. It's at a rate and intensity above expectations for peers, it's beyond cultural norms, and it's outside the range of normal developmental expectations. Now, these types of characteristics, they must be observable in at least two different settings. Alrighties, it has to be either at school and at home, in the community and the home, but at least two different settings. It also has to have existed over a long period of time. So we're looking at about 6 months range here, folks, alrighty? There has to be some sort of pattern or trend for some time. It's not a one and done deal. So it's not an isolated incident or experience, alrighties? So, quick question for you all. Emotional behavioral disturbance, is it a recognized DSM classification? So take a moment and think about that. Is EBD in the DSM-5? True or false? The answer is false. In the DSM, right here are the things listed or classified under the DSM. So we've got schizophrenia, we've got bipolar, we've got depression, we've got anxiety, OCD, trauma and stressor-related disorders such as PTSD, post-traumatic stress disorder, eating disorders, impulse control disorders, conduct disorders. Those are the things under the DSM-5. They're much more specific, as you may notice. Again, EBD is a catch-all umbrella term. Educational classifications. So we know that children who are struggling emotionally or behaviorally and it's diagnosed, they're going to need some level of special education and related services in order to make progress at school. Usual eligibilities would be ED, your emotional disturbance, or OHI, other health impairment. Now, eligibility does not dictate classroom placement, guys. Now, I tend to see a lot of students who struggle with emotionality, they immediately get placed into the ED classroom just because of their emotional challenges. Remember, your assessment has to support that placement. You can't just, because of their emotionality, instantaneously place them into a ED uh, program. Know that many students who have emotional issues, they're going to succeed in a regular education classroom with the appropriate supports. So let's take a moment and talk about ED and the DSM. I want you to take this time and pause and think. There is going to be a form uploaded onto Blackboard. It's ED versus the DSM. So take a moment right now and pull that form up. Alrighties? So pause this video if you have to and go and retrieve that form. I want you to take a look at on the ED side under IDEA regulations. I want you to compare it to the DSM side. You'll see that there are some overlap, there are some differences, as well as there are some similarities. I want you to, again, pause this video and take a look at ED side and DSM side and answer these questions. Not so much answer, but ponder these questions. What are those general overlaps? What are some similarities? And then if this form had it not been labeled ED versus DSM, how would you know which side is the ED criteria versus the DSM criteria? Things to think about, okay? So take a pause. Take as long as you need to go over that particular form. Alrighties. And here we go. Let's move forward to the next slide. So we've got some common characteristics of kiddos who struggle with EBD issues. So they may engage in hyperactivity, they have a really hard time focusing, they can be impulsive, they can be aggressive, maybe they engage in self-injurious behaviors, they can be withdrawn, maybe they lack maturity, they may have difficulties learning, they may have distorted thinking, bizarre motor acts, abnormal mood swings. These are some of the common characteristics. So how do these characteristics manifest themselves? So we've got internalizing and externalizing manifestations of emotional behavioral disorders. Internalizing, just like the name states so, it's being kept in, alrighties? So all of these difficulties are being bottled inside. So what does that look like in terms of internalizing? It may look like painful shyness or withdrawal. It could be a lot of worries. It could be maybe panic in certain situations. It could be low self-esteem. It could be disengagement or maybe suicidal ideation and possibly even anorexia or bulimia, eating disorders. To add to that, there's also the externalizing manifestations, and these are acting out, right? You're acting out into your environment or in opposition to others in your environment. So these are students who may cause or threaten harm to others. They may use obscene gestures or language. They may ignore directions. They could be verbally hostile. They may have tantrums. They may damage property. They may violate rights of others. They may struggle to understand or read social cues, and they may not really understand the sense of fairness or justice. So let's go ahead and take a look at these videos.
In any classroom, every child is different. Some seem quiet. Some seem boisterous. And some switch between, depending on what's happening. But when a clear pattern of behaviour begins to impact on a child's functioning, this might be a sign of a mental health difficulty. And there are two types of these. When they feel strong emotions, each child expresses them differently. A child who externalizes feelings can let out those high emotions in all sorts of ways, where a child who internalizes feelings can show many quite different signs that he or she is bottling things in, even physiological ones. Of course, all children are too complex to be placed simply in this box or that. Nonetheless, these two types are still handy for remembering the different ways that mental health difficulties can begin to show in the classroom.
Once you take a mental health lens, teachers inevitably start to think about, well, what should I be watching for in class? Are there kids that I should be sort of flagging as in need of follow-up or maybe even assessment? Well, I guess one easy rule of thumb as a teacher is to say, well, the kids who are acting up, they already have my attention. But should I think of these challenging behaviours as also symptoms rather than just problems? Maybe investigate that. For the kids in the middle, the ones who maybe slip under the radar very easily, the ones that you maybe never catch yourself interacting directly with, they're not a problem, they're not standing out anyway, have another think about them. Are some of those very quiet children in need of more care and attention? Why are they so quiet? Is that a good thing, or is there something maybe not going quite right for them? And I think the third category, and sometimes we miss this one in teaching, is the high-achieving child scholastically. We can feel great about those kids. They're the evidence that we must be doing our job really, really well as well. But actually being a high achiever, if you're not also strongly socially connected, is a particular vulnerability in Australian schools. And that shows up in our data around mental health vulnerabilities, around children maybe who suffer from a degree of anxiety. So I also have a look at those high-achieving children and make sure that there's also good work going on to ensure that they're highly socially connected as well as connected to learning.
I think we have to be very careful about applying a diagnostic category to a child. Partly, development is fluid. Quite a few of the difficulties that we do see at one point in time, if it's only happened at one point in time with a child, are likely to be transitory. They're likely to be reactions to particular stresses that they're having in their lives at that particular time, and to disappear with, if they don't encounter other nasty things along the way. So that's one reason why you might be applying a label to a child which then no longer gets to be appropriate. And for the large bulk of children, applying a label doesn't really matter so much. It's having a clear picture of what sorts of difficulties the child is facing.
Aha. Alrighty, folks. Now, if you haven't done so already, please make sure that you have that Sam and Barry form out and open, because you're going to take some observational notes as we watch this video clip regarding Sam and Barry, and fill in the appropriate boxes for the observations that you see.
What's the matter? Scared? Don't worry. I'll go easy on you this time. Come on, Loose Chester. See what you got. Come on, freak!
Look, this is the third school we've been to this year, and it's only November. I'm just sick of always being the new kid.
You'll be fine. If anyone gives you any trouble, you let me know. Relax.
Ladies and gentlemen, please say hello to Sam Winchester.
Hi, Sam.
Is there anything you'd like to tell us about yourself?
Not really.
Okay, grab a seat.
Whoa, that's yours. Awesome. Hey, I'm Mary.
Now I want 3 pages on your most memorable family experience. Just a reminder, though.
Essay assignments. Yeah, my heart breaks for you.
This is going to be worth half your final grade.
Leave him alone.
Screw it up.
Going for a record.
Now, what you write about
I
is
said
less
leave him
important
alone.
to me than how you write about it. I want Okay, everybody, if you have any questions? All right, let's get started. Good luck.
You want to take his place?
Okay.
Midget?
Or bad. I'm looking for the brutal, funny,
Yeah.
maybe even the...
Sure.
Gotta watch where you're going, man.
Leave him alone, you jerk.
You never learn, do you, midget?
Thanks, Sam. Great school.
Hey, tough guy. I've been looking for you.
Get to the bus, Barry.
What's the matter? Scared?
I don't care. It's 3 years and I'm out of here. Going to Michigan State. They got the best vet program in the country.
You like animals?
They're a lot nicer than people.
Still want to take Barry's place?
Get out of here, Barry.
I'll go get a teacher.
Don't worry. I'll go easy on you this time. Come on, Loose Chester. See what you got. Come on, freak! Freak! Want to go?
I'm not gonna fight you, jerk.
Why not? Chicken? Come on!
No.
Get up! Get up! Come on, get up!
Get back! Get back! That is enough. Dirk? Dirk! Stop.
You're not tough. You're just a jerk. Dirk the jerk.
Hey, Dirk the Jerk. Yeah, that's pretty good. Dirk the Jerk! Dirk the Jerk! Dirk the Jerk!
Alrighty, so take a moment and make sure you completely filled out that Sam and Barry form. Again, that form is something that you're going to be uploading onto our Blackboard discussion board post. Alrighty? Okay, let's continue. In terms of that manifestation of EBD, when we look at these areas of cognitive, language, academic, and behavior, this is what we're seeing. In terms of that cognitive piece, we're seeing these students possess what's called low average to average intellectual abilities. So they're pretty smart. And then in terms of language, however, we're starting to see some deficits here with that pragmatic language, which is the ability to use language in a socially appropriate way. They're having trouble with expressive language, so verbally expressing themselves, and also the receptive language. So in terms of understanding spoken language, they're having difficulties with that as well. With the academic piece, there you can see that these are students who may have been retained. They may have had a lot of failure throughout their academic career. They may have had a lot of absences. They may have even been at risk for dropping out. With behavior, you're going to see that I upload onto Blackboard some behavioral characteristics of EBD. Please pause this video and take a look at that form. Alrighties, just so you get a sense of what these characteristics look like in terms of behaviors. Alrighties. So let's talk about more specific EBD difficulties or disorders. Specifically, let's start off with anxiety. So these are our students who have a lot of worries. They're worried about everything. Um, in terms of behaviors, these are students who may often be absent because they're so scared or worried about, say, going to school. They may engage in a lot of isolating behaviors. They may complain about physical symptoms. So this is where they may go to the nurse often. So check in with your nurse. They may have frequent bouts of tears. They cry often. They may engage in a lot of frustration. They have a lot of fears about being separated from caretakers. They may avoid school. They may be fearful about new situations, such as like a field trip. Then later, maybe perhaps adolescence. During adolescence, you may see them engage in at-risk behaviors, such as drug or alcohol abuse. And you also might want to see a follow-up with looking into obsessive compulsive disorder, which is also outlined in this presentation, as well as PTSD, post-traumatic stress disorder. With depression, so we know that it can affect thoughts, feelings, behaviors, relationships. For children, you see children who are depressed, they often engage in irritable behaviors. They can be defiant, they can be restless, they can be very clingy to their caretakers. There's always this pervasive mood of unhappiness. You look at this kiddo and you notice, dang, all I see is a very, very sad kiddo. I don't really see a very happy child here. They may be very hopeless about things. They may have self-deprecating remarks. They don't really believe in themselves. They may avoid school. Perhaps they may exhibit change eating or sleeping patterns. They may have a lot of complaints about physical well-being. They may engage in isolation or may not participate or engage with peers. Students with schizophrenia. Now, these are students, if you're going to be working, say, at a high school, this is where we start to see schizophrenia develop around the high school time, teenage years, or early adulthood. It comes on very gradually, alrighties. It may start off as, say, other types of diagnoses if they are diagnosed by a medical provider, and then it gradually evolves into schizophrenia. We know that the earlier that children and youth get diagnosed, then treatment is really, really important in terms of that early intervention. This is our way of preventing any attempts at suicide because we know 50% or more may attempt suicide at some point. Students with schizophrenia may become very withdrawn, they may lack motivation, they may have bizarre thoughts or speech. There may be this confusion between what's real and what's fantasy. They may have hallucinations, those are visual, or delusions, and those are very auditory. They have a lot of fear. I mean, can you imagine if you are trying to get along with your day, go about your day, and you've got, let's say, auditory, you're seeing things that aren't really there. It's very scary. It's very, very scary. Or you're hearing things that others aren't hearing. It can be very disorienting. They may have odd regressive behavior, very disorganized speech. You may not understand somebody with schizophrenia when they're trying to explain things to you. Students with oppositional defiance disorder, ODD. These are students who have above average levels of anger, blaming. They can be very hostile and have a very vindictive behavior. They may possess a lot of frustration, depression, and it's always in reaction to inconsistent structures or constant failure. Perhaps there's been undiagnosed ADHD or learning disabilities. There's a lot of angry outbursts, and at times they can be non-compliant or argumentative, easily annoyed. They don't really like praise, guys, especially from a person in an authority role. It really bothers them, alrighties. They may deliberately annoy or provoke others or engage in self-sabotaging types of activities. Conduct disorder. This is students who consistently, repetitively go against social norms. They're rule breakers. Alrighty, it's a lot of misbehavior. They may have aggression towards people or animals. They may destroy property, maybe engage in theft. Perhaps 3 or more incidents in last year, maybe one during the last 6 months. If say you're doing an assessment on a student suspected of ED and their particular emotional difficulty is conduct disorder, you want to look and see if there's been incidents in the last year or one during the last 6 months. So the problem must be persistent. Again, it's not a one and done experience or behavior. It has to be persistent. It can co-occur with ADHD, learning disabilities, or depression. And again, this tends to align with ODD, oppositional defiance disorder. In terms of reactive attachment disorder, so if you're working with the little ones, say pre-K, now, this isn't common, but there may be students who may have reactive attachment disorder. And for students who have this disorder or RAD, then it manifests itself as extreme aloofness. It can be very destructive. It can be very behavioral in nature. There can be bits of rage and mood swings, and it tends to happen before age 5, and it's in response to a period of having inadequate care or some level of neglect or abuse. So let's go ahead and take a look at Julia.
Okay, now
I'll go first. All right.
Gloria.
Gloria, what about some tomatoes?
That's it.
They're funny.
see if Gloria will have some.
Dad, look. You take this
I
off.
doubt it.
It's too cold.
Then you open the thing, and then you get the eggs if there are any.
Oh, look at that.
You're lucky.
Excellent.
Just
Excellent.
look around.
I knew something wasn't right early on. We adopted Julia from a Siberian orphanage in February 2003. She didn't clutch to me or gaze in my eye. She never rested her head on my shoulder or relaxed into a warm embrace. She didn't respond if I sang or read to her. She was there, but wasn't.
This is Alex. She's my favorite cat. She's the third cat in the house. She always sleeps right next to me on the bed. This is Smudge right here. He licks, actually. He has lots of smudges on his face. That's why he called him Smudge. He's a nice cat. He's very obedient. He looks at you in the camera.
In January of 2003, we traveled for the first time to Novosibirsk in Siberia, and we met her, and it was surreal. I will always have that picture embedded in my mind when the caretaker walked toward me and she was cradled in her arms. That first time I looked at her, I thought I had never seen a more beautiful baby anywhere. I mean, she was so starkly stunning. She already seemed to have like dimples, and she had these khaki colored eyes, and she had a runny nose and it was red, but she had this alabaster skin, and she was like a piece of porcelain. She was stunning, absolutely stunning. I guess the first thing I thought of was, wow, she must have some stunning mother.
And the other animal we have in the house is me. I'm like the wild monkey.
By the end of maybe the first year, I was really in despair. I had just come to conclude that I had made a mistake and that something must be wrong with me, that I couldn't feel connected to this child. She was always running away from me. She, just never, there was no mother duckling, baby duckling thing going on. There was no sense that, I was the person who was going to protect her. And there was nothing warm. There was nothing fuzzy. I couldn't read to her. I couldn't play with her. It was just like she was there. And the more time went on and the more it was like that, the worse it felt.
I want to become a special ed teacher which is a teacher who teaches other people, teaches sort of like special and disabled people. And I want to do that because I sort of feel like connected to them in a way. Not really, but I really like them and I have a giant interest in them.
What reactive attachment disorder is, briefly, is that the baby suffers a traumatic disconnect from love and nurture and care so early on. And they come to believe in their subconscious mind, even though they're so young, that the world is an unsafe place, that there's no one to trust, that adults come and go, that there's very little consistency. And ultimately, they absorb this idea into their tiny little minds, but these little minds are forceful. And they absorb this notion that the only people in the world they can trust are themselves. From that moment forward, everything, I mean, I'm not saying it was instantaneous change, but everything about our intentions of how we were going to parent her changed. Julie's always been an early riser, so we all usually wake between 6 and 6:30. And while Ricky was out getting the chickens out of the coop, Julia and I come downstairs, and I made some fresh squeezed orange juice, and we laid the table for breakfast, and we got the newspapers on the table, so by the time Ricky comes in, the cats are fed, and we sit down and we eat some breakfast. Ricky got busy in the kitchen baking his soon-to-be famous madeleines, and after breakfast, we spent some time back in Julia's room, looking at some of her, the website that she's making about cooking, and also some drawings, some cartoons that she's made, including a drawing that made it into Highlights magazine. And then she played a game of chess with her dad, and he stole her queen, and she wasn't too thrilled about that. But she got over it very quickly, especially since lunch was next, and eating is very much up there among the favorite activities. So we had our typical, Sunday lunch, a nice big salad and some mozzarella sandwiches. And the rest of the afternoon we'll just unwind lazily. Julia will be on the computer for an hour or so. We'll probably just laze around and maybe do some work or read. And then we'll probably have a light dinner tonight before we watch the Oscars. She's become, she's everything. I mean, she's my child, and it's like she's my work, and the two have fused together, and it's kind of gratifying in a funny sort of way. I mean, I guess what she's brought to my life in a weird way, and I hope this doesn't sound selfish, but she's brought to my life a mission. Julia's hurt has given us all a mission to heal, and that I'm able to do that through my work makes me very lucky. I've not just been given a child, but I've been given a muse,
Alrighty, so that essentially was what we would say a very happy ending, right? Not so much ending, but it's a very positive outcome in terms of the structure and this love that was in this household that really addressed some of these reactive attachment related difficulties. All right, as we move forward, bipolar. So this is extreme mood swings, alrighty, guys. And there's various types. There's two types specifically, but we just want you to know the very general, broad what bipolar disorder is. So it's these frequent, intense shifts in mood, energy, or motivation. And in children specifically, these shifts can be very fast and unpredictable. In one moment, this child could be happy, and the next moment, they could be ultra sad. Alrighties. And there's also this phrase called mania, and it may appear as very intense irritability or rages, or lots of just flooding thoughts and hyperactivity and lack of sleep, inability to sleep even. There could be some levels of anxiety associated with this. There could be strong cravings for things. It can lead to impaired judgment or impulsivity. This is where you see folks may end up buying things if they have the means to, or even if they don't have the means to, putting things on credit card, just being engaging very impulsively. They may have delusions, whether it's grandiose ideas like they are Jesus Christ, the second coming of Christ, or they can possibly have hallucinations. These folks tend to be very at high risk for suicide and accidents, especially in that mania mode where they feel as though they are invincible. Those accidents where they believe maybe they can fly. And then it's really during the lows with that slight bit of energy, the low going into a little bit of a high, but not the mania phase yet, where they may be at an increased risk for suicide. In terms of OCD, so just as the name states so, obsessive compulsive disorder. Obsessions are thoughts, all right? You've got these recurring, repeated thoughts in your mind, which leads to these compulsions or actions to alleviate some of the anxiety induced by these thoughts. So you've got, maybe you need to engage in particular actions or rituals to appease some of these anxiety related thoughts. Now, OCD can co-occur with substance abuse as well as ADHD, eating disorders, Tourette syndrome, and other anxiety related disorders. And children or youth who have OCD, they have a really hard time finishing work on time because there's a need to make everything absolutely perfect, or it has to look a certain way. They may engage in ritual rewriting or erasing things and starting over, erasing it and then doing it again, etc., etc. They can engage in counting things over and over, maybe counting steps, maybe turning the knob this number of times before actually opening the door. They may exhibit poor concentration. They may avoid school. And of course, they have a lot of anxiety as well as depression. And it becomes a sick cycle because if you have OCD and you have to engage in all these rituals to be able to function, your relationships are going to be impacted because let's say it takes you an hour to turn the doorknob this many times in order to leave your home. You end up being late to your appointment with your friends. Your friends get frustrated with you. They don't want to see you anymore. So it then becomes a very sick cycle. With PTSD, post-traumatic stress disorder, these particularly affect children who have been involved in or witnessed a traumatic event. Now, we're particularly concerned with the refugee population, especially refugees who fled war, where they've seen a lot of trauma, deaths perhaps, etc. And I remember when I was working at Garden Grove Unified, again, we had an influx of Syrian refugees, and I remember working with a pair of twins, and I remember just the things that I uncovered through their records, the things that they have witnessed. It was just so troubling for any second grader to have to see with their eyes because they were so little. It just seems so striking because second graders, you want something a little bit more resemblance of childhood instead of all these atrocities that these families, these refugee families experience. There may be intense fear and helplessness, maybe even flashbacks. Maybe there's a trigger of sort. I know that at particular schools, perhaps they decided to turn off their bell because the bell could be a trigger for some students. They could have nightmares. Maybe they reenact what they saw in play. There could be a level of emotional distress when they experience things that remind them of that particular traumatic incident. They could have fears of certain places, people, or events. They can be easily startled or irritable, hostile. They may have physical symptoms like headaches or dizziness. When it comes to eating disorders, specifically anorexia or bulimia, the difference between these two guys is anorexia, you are essentially not eating. Alrighties, you are not eating to gain control over your intake of food. Bulimia, you're eating, but you end up throwing up and vomiting all that you eat. Again, to control your intake of food. And it also goes back to a very, very impaired preoccupation with appearance. All right. And we tend to see these types of eating disorders in folks who are very perfectionist. There can be overachievers. They can be athletes. These are folks who tend to be at highest risk. And the root of it is, again, anxiety. These are also folks who are very high risk for depression, alcohol, and drug abuse. They may exhibit impaired concentration. They can become withdrawn, anxious, depressed, irritable. They may have fainting spells. And the fainting spell really is associated with not getting enough food in your system. Alrighties, your body essentially is dying and is so hungry. All right, so causes of EBD, emotional behavioral disorders, we know that it comes from multiple elements. One of these elements is the biological component. So you've got your genes. Can't help your genes. You inherit it from your family, right? Or perhaps some abnormalities in neurological or biochemical development, things going on in your brain, the chemicals in your brain. It could be a result of head injuries, traumatic brain injury, for instance. It can be psychoanalytical factors, perhaps a traumatic childhood experience, abuse or neglect, perhaps, and by extension of that, we're talking about adverse childhood experiences. If you had a traumatic experience in your childhood, that could also impact the makeup of the brain and how you develop. And there can also be environmental elements. So exposure to maladaptive behaviors, perhaps you had particular family members who modeled things, certain things. Perhaps there's environmental stresses like poverty, violence, perhaps even social rejection. So, as we continue talking about causes, some of the things to keep in mind are potential risk factors. We know that both biological and psychosocial factors impact the brain and its development. Alrighties, we know that brain disorders tend to cluster in families, showing that there's some type of genetic thing going on here. We know that symptoms relate to damage due to injury, infection, even poor nutrition, and even exposure to toxins. So, for instance, the lead exposure in certain paints that families who lived in apartment complexes painted with lead-filled paint, right? It can be stressful life events like childhood maltreatment or even abuse. Those all increase the likelihood of adverse outcomes. So I want you to take a look at this visual right now. This is a comparison of 2 3-year-old children. You've got on the left there a child with a normal developing brain. On the right, you've got a child that has experienced extreme neglect. What are the differences? Take a moment and think about the differences between these two brains. Hope you're thinking about it, because I'm going to dive right in and say some things. Alrighties. So, first things first, the size, right? Look at the size of the child with a normal developing brain. Their brain is bigger, alrighties? Whereas the child that has experienced extreme neglect, their brain is much, much smaller. In terms of just how full the brain is. The child with the normal brain, you can see that there's much more, their brain is much more full, right? There's not a lot of black space when compared to, say, the child that has experienced extreme neglect. That tells you the child with the normal brain, there's a lot of connections in their brain. Their neurons are being connected and firing away. Whereas the child that has experienced extreme neglect, they're not having a lot of connections in their brain because they're not receiving that stimulation from their environment. Alrighty, folks? Isn't that fascinating? It goes to show you, folks, if you have children, people, please, okay, you can't return children, alrighties, folks? This is a very serious decision, okay? Alrighties, I'll get off of that. Okay, So let's talk about the frequency of EBD. The CDC has estimated 8.3 million children ages 4 to 17 are referred to healthcare providers for these emotional behavioral difficulties. And nearly 2.9 million children have been prescribed medication for these emotional and behavioral concerns. In terms of assessment, that's what you all do. That's what we as school psychologists do. Alrighties? You will notice on Blackboard, I have uploaded for you a document which outlines how to assess EBD. Okay, it is a document that's created by CASP. Alrighties, it even goes over what questions to ask. How do you establish rapport? What is the mental status examination? Please save that, alrighties, because once you go into internship, once you become a practitioner, you can always go back to it in terms of assessing kiddos that are suspected of ED. Alrighties. So first things first, you want to observe this kiddo in multiple settings. Alrighties, does this behavior occur in all those settings? Alrighties, you can even conduct a mental status examination. This is looking at physical attributes related to mental well-being or mental health. And again, that document I uploaded onto Blackboard will have those specific areas and what to look for. You're going to interview folks, multiple people. You're going to interview the student, the parent, the teachers. You're going to do a record review. You're going to look at disciplinary records, medical records, if possible, especially if you are unable to access medical records, make sure you sign a release of information so that you can access those medical records. You want to do rating scales and try to include the student as well so that you can gather information on their self-perception of things. You want to make sure you engage in non-discriminatory evaluation procedures. You want to collect cognitive abilities, academic abilities, adaptive abilities, as well as psychological processing abilities. The psychological processing abilities is going to tell us if there's any bizarre thoughts or disconnect with reality that this student might possess. You also want to make sure your SLP is on board to take a look at language in terms of that pragmatic, the receptive, the social language, what's going on there. And if there's a lot of behavioral concerns as well, conduct an FBA if you need to. So you also want to make sure you bring in some broadband social emotional tools such as the BASC or the Connors behavioral rating scales. You also want to take a look at some narrow, specific social emotional tools. So this can mean the emotional disturbance decision tree, the children's depression inventory, the Beck's depression inventory. The difference between broad and narrow is that the narrow band social emotional tools look at specific disorders like depression, alrighty, or anxiety. Whereas the broad band social emotional tools are looking at things much more, you called it, broadly. Projective tests. Okay, folks. If you want to engage in projective tests, that's fine. But just know that the research does not support projective tests because it is so subjective. And if you are not trained to interpret projective tests, you could inaccurately perform an analysis, and then it won't give you valid information. Alrighties, just because there is so completely, there's no way to repeat. So in a way, you're unable to repeat this task time after time and get the exact same response each time because it's so subjective. It could depend on the child's mood. Maybe they see a butterfly on the Rorschach one day and they see a rat the next day. It is so subjective, folks. That's why validity is questioned, alrighty? In terms of intervention, there's 5 levels or types of interventions with EBD kiddos. You can examine things from an environmental lens, a behavioral lens, an academic lens, the moral affective development, or counseling and therapy approach. And best practices tells you at least 2 combined approaches together. Alrighty, folks? So, for instance, like environment and academics, or behavioral management and counseling. Alrighty? not just reliance on one level or type of intervention. For kiddos with EBD, you want to make sure it's a combination of at least two types. So let's talk about environment a little bit more in depth. So things such as smaller class sizes, student advocacy systems, adaptive equipment, queuing systems, schedules and routines, room design, noise levels. Those are the things that we would see in terms of the environment when it comes to interventions for EBD kiddos. With the behavioral piece, we're looking at changing or modifying or adjusting that behavior. So we're doing a lot of, say, setting up the classroom management, or we're engaging in procedures and modifications in terms of helping the student follow rules. We're making sure that rules are posted all over the classroom so that everybody understands what the rules are. And then there's a lot of guidance to how to respond in a particular situation. And how do you collect that data to build your behavior management protocol? You may do a BIP, you may do an FBA, you can do an ABC analysis, which is that antecedent behavioral consequence analysis. You can do positive or negative reinforcement analysis as well and see what the child responds to. With the academics, you want to make sure that there's well-defined limits and rules. You want to make sure there's consistent routines, there's verbal reinforcements for appropriate behaviors, there's planned ignoring of inappropriate behaviors, there's reminders, there's earned activities and privileges, self-monitoring systems, token economies, and even a homeschool reward plan. That ensures that there's consistency and communication between school and home. That moral affective development, you want to make sure that you identify appropriate expression of feelings. What's appropriate and what's inappropriate. You want to make sure that you teach about personal awareness. You want to teach communication, problem solving, decision making, group and systems understanding. What counts as a significant relationship, lifestyle choices, coping strategies, how to manage stress, and how to life plan. In terms of counseling and therapy, you may engage in school-based counseling where you're working on mental health goals, alrighties? Maybe there's also wraparound services in the community. You're consulting, collaborating with community agencies. Perhaps there's a family therapy component. Perhaps there's also psychiatric care involved. Say you are also working with an outside provider and you guys are working on a particular plan to support the student at school, at home, and in the community. So let's go ahead and take a moment and talk about social maladjustment. So with social maladjustment, we know that IDIA states that a child that is socially maladjusted is not an individual with exceptional needs. So therefore, that means that they're not a child that needs special education related services, unless, folks, they have been identified as having some sort of emotional disturbance or emotional difficulty. A student that is socially maladjusted typically has voluntary patterns of actions and an ability to control their behavior. Alrighty, folks? Children with emotional disturbance, on the other hand, there's no way for them to control their responses and reactions. It's very involuntary. A child who's socially maladjusted, typically they're in conflict with established value systems. But the child that is seriously emotionally disturbed, however, there's a lot of inner things going on, psychological tensions and anxieties. A child who is socially maladjusted, they usually can adapt to their behavior in terms of what is the social demand at that time. Alrighty, especially if their behavior provides a source of personal reinforcement. In the education setting, guys, a social maladjusted student does not value academic achievement. They're often frequently truant or rebellious, but they have the ability to function in the school and our community, although maybe not according to what's generally accepted or the standards that's generally accepted. And also, I have a form that I have uploaded onto Blackboard for you guys that compares the difference between a socially maladjusted kiddo versus a ED kiddo. Alrighties. So with that, folks, go ahead and make sure you upload Sam and Barry, your responses, your notes to Sam and Barry onto our Blackboard discussion board post. Alrighties. Okay, now moving on to SLD.